Okay, so today we are going to discuss the aortic stenosis of for pathology or the pathology of the aortic stenosis. So, actually, about the patient came to surgical PD for pre-assessment of his angular hernia repair, examination, and ESM with splitting ejection systolic murmur. Examination and ejection systolic murmur with splitting of S2 was found, and you will be asked about this is concern in this pathology station. So what is your proper diagnosis of this patient? So this is aortic stenosis. Ejection systolic murmur is always found in aortic stenosis plus with the S2 split. S2 split or it is also called as a paradoxical split which occurs in aortic stenosis. So what are the causes of aortic stenosis in this patient? So post-inflammatory scarring can occur. For example, rheumatic heart disease, senile calcific aortic stenosis, calcification of the disease wall. So, what are the causes of aortic stenosis in this patient? So, first of all, the patient is of old age, so there can be, since the patient is 60 or older, so there can be senile calcific aortic stenosis or sclerosis. There is in old age patient there may be calcification of the disease walls, and there can be rheumatic heart disease. So rheumatic heart disease usually leads to the formation of scarred valves. So rheumatic heart disease, senile calcific aortic stenosis, and calcification of the disease wall. Other causes of aortic wall disease. So other causes are the aortic stenosis and aortic regurgitation. Okay, so other causes of aortic wall disease. So it can be aortic stenosis can be congenital, can be due to say or secondary to rheumatic heart disease, acquired calcification and fibrosis of the wall, and aortic regurgitation can be because of rheumatic heart disease, infective endocarditis, congenital, inflammatory, for example in systemic lupus erythematosus, SLE, rheumatic ankylosing spondylitis, and dilatation of aortic root in Marfan syndrome and dissection and Ehlers-Danlos syndrome. And then we have systemic disease, for example, syphilis. Syphilis can also cause this aortic regurg. So, syphilis, ulcerative colitis. What would be the expected clinical picture of this patient? So, expected clinical picture of this patient will be like the patient will have like clinically he will present with a murmur, ejection systolic murmur, and also there will be paradoxical S2 split on physical examination and clinically, and there will be like left ventricular hypertrophy, which will lead to the increase in the pulmonary hypertension, and there can be ischemia, which can lead to on long term to myocardial infarction and congestive heart failure. And causes of sudden death in aortic stenosis or MI and aortic dissection. How stenosis occurs? So lipid accumulation, inflammation, and calcification of the wall leaves. This leads to wall thickening and stenosis. What is the pathophysiology of aortic stenosis? Means like how aortic stenosis occurs. So as the aortic wall progresses from sclerosis to stenosis, the left ventricle encounter chronic resistance to systolic ejection, increase after load. So there will be thickening of the left ventricle wall hypertrophy. Effects of high left ventricular after load include decreased left ventricular myocardial elasticity and coronary blood flow, and increased myocardial workload, oxygen consumption, and motility. Late manifestation of left ventricular hypertrophy include smaller left ventricular chamber size, which decreases preload and means that and worsens systolic dysfunction, and there will be the result is insufficient stroke volume, cardiac output, and ejection fraction. Finally, backward transmission of the increased left ventricular pressure to the lungs may cause a pulmonary venous hypertension and reactive vasoconstriction of the pulmonary vasculature. Remember, whenever there is a hypoxia in lungs, so the pulmonary, this is the problem with the pulmonary vessels that they constrict. Why? Because this is a physiological mechanism. So they always constrict so to shunt the blood flow towards the high oxygen areas. So there will be pulmonary vasculature. So it will leads to hypertension, pulmonary hypertension. And okay, so what investigation would you like to do? I will do a chest X-ray to check cardiomegaly due to left ventricular hypertrophy, and to see the calcific aortic ring. Uh, X-ray, so calcification is a hypertense, so it will be shown on X-ray. I will do ECG, 2D echocardiography, transesophageal echocardiography, and coronary angiogram. In ECG, what do you expect? So the ECG of aortic stenosis patient will show uh, the high QRS complexes in chest leads V1, V2, V3, and there will be which shows hypertrophy of the left ventricle, and there will be um, a left excess deviation as well. Okay, in 2D echocardiography, bicuspid aortic valve was found. Why is bicuspid aortic valve susceptible to infective endocarditis? Because there is increased risk of stenosis, stasis of blood, or there will be turbulent flow of blood, so they are very exposed to infective endocarditis. And pathogenesis of infective endocarditis and bicuspid valve. So nerving of the valve, because if the valve is bicuspid, and in comparison to it, if a valve has three leaves, so three-leaf valve is like has more opening, wider opening as compared to two leaves opening or bicuspid valve. So there will be narrowing of the valve, stasis of the blood, increased chance of bacterial colonization on the walls, and recurrent inflammation and fibrosis and scarring of the wall later on. So aortic wall endocarditis after a valve weakness in the arm. Why? Thromboembolism, which leads to cerebrovascular stroke. So that okay, so a patient has aortic wall endocarditis, and after a while there is a weakness in the arm. Why? It is because of the stroke, cerebrovascular event. Which coagulation system will not be affected by warfarin intrinsic pathway? Define thrombus. Thrombus is defined as a solid material found by the constitution of blood in flowing blood. So it is a solid material found by the constitution of blood in flowing blood. Okay, so remember that thrombus is always formed of the um, platelets and the fibrin threads. So, and on the contrary, clot is only formed of fibrin. In clot, there is no platelets. So this is the difference between clot and platelets. Thrombus. What type of complication happens to non-displaced thrombus? It can be propagated, like it can increase in size, infected, form granulation. What test will you do if you suspect that the thrombus is infected? So I will do CBC to check for leukocytosis. I will do CRP, acute inflammatory protein. I will do ESR and blood culture. What is CRP? What will you look for in blood culture? C-reactive protein, which is an acute phase reactant produced by the liver. I will look for gram-positive, gram-negative, and anaerobic in Hesse group. What is the type of endocarditis that occurs with the adenocarcinoma? Liebman-Sachs endocarditis. And Liebman-Sachs endocarditis usually occur with the most commonly with SLE, but it can occur in adenocarcinoma. Plus, in adenocarcinoma, there will be a non-thrombotic endocarditis. What is the antibiotic guidelines in patient with the aortic stenosis? So, NIGHT guidelines prophylactic antibiotic prior to delta procedure is no longer routinely recommended unless major procedure and highly infective procedure is done. For example, infectious one and a prosthetic valve, prior infective endocarditis, and okay, so you have to give in high infective case, and also in prosthetic valve case, and prior infective endocarditis. Like a patient has a prosthetic valve, so you have to give him antibiotics if he is undergoing any surgery. And if somebody has a history of infective endocarditis and a history of cortical transplantation and chronic heart disease with some criteria. Science Scottish Intercollegiate Guideline Network. No need. Also, the Scottish guideline also say that there is no need of appropriate antibiotics. What are the surgical options for wall replacement? So, mechanical wall, a long-lasting wall made of a durable material. Tissue wall, which may include a human or animal donor tissue. Ross procedure, borrowing healthy wall and moving it into position of the damaged aortic wall. And TAVI or TAVR procedure. So it is transcatheter aortic wall replacement. Transcatheter aortic wall uh, replacement. And alternative options include aortic wall balloon valvuloplasty. The wall is widened using a balloon. Aortic wall balloon valvuloplasty. Aortic wall balloon. If metallic wall replacement was done and the patient were infective endocarditis, why the wall should be removed? What is your next step? The wall will be septic focus, and the wall will be dehiscent, and it will be difficult to treat it with antibiotic as the wall has no blood supply and due to the formation of biofilm around the prosthesis. So you have to remove it, and you have to do debridement and clean it. What would be the histopathology findings of the removed wall? So the removed wall will have fresh vegetations, contain platelets and fibrin with a rich infiltrate of neutrophils. Colonies of embedded organism may be seen. Organizing and organized thrombi with fibrosis are common in lesions that have been present for weeks. And in chronic lesions of vegetation may show varying degrees of organization, vascularization, and calcification. Commonest bacteria to cause infective endocarditis in prosthetic wall, Staphylococcus epidermidis. If we found a microscopic branching hyphae on a removed metallic wall, what is the cause? Fungus. This is fungal infection. Candida aspergillus, microsporum, trichophyton, and epidermophyton. Trichophyton, epidermophyton, aspergillus, candida, and microsporum. Microsporum furfur. Before starting a warfarin, what instruction should be given to the patient? MRI caution and antibiotic prophylaxis, warfarin and its uses. So I will counsel the patient regarding the warfarin and its uses. I will brief him about this, and I will also tell him about the antibiotic prophylaxis, and I will tell him about the MRI caution. What are the types of wall? Okay, so whenever you are starting a patient or warfarin, so he must have some walls, prosthetic walls. So that's why MRI caution. What are the types of valve available? Differences between them. So walls can be mechanical and tissue. So tissue walls are noiseless and the mechanical walls are noisy. The mechanical are excellent durability with 95% to 10 years, low rate of reoperation. And in mechanical you have to give the patient lifelong warfarin, and it is easy to insert, and the thromboembolism is 1 to 2% per patient per year. Bleeding risk is 2% per patient and per year. And on the other hand, in tissue walls there is a low risk of bleeding, 0 to 1%, low risk of thromboembolism, 0 to 1% as well. And the tissue walls are more difficult to insert, whereas mechanical are easy to insert. Or tissue walls do not require lifelong warfarin therapy. It is mandatory only in the first 3 months after wall replacement. Yes,